Good morning, everyone. I'm Karthik Guja. I'm live from New York. I'd like to invite you for the monthly peripheral endovascular live case. Before we go to the live case, I would like to send out an invitation from Dr. Sharma for our annual Top 10 Advances in Cardiology Symposium, which is being held on October 7th. Please go to cccsymposium.org to register and for more details. We would like to hear more questions from you after this live case on peripheral at info@peripheраlinterventions.org. Our previous live case has been in the archive at peripheраlinterventions.org. Without any delay, I would take us to the lab. PK, good morning.
Good morning. Hi, Karthik. Good morning. It's a pleasure to welcome all of you back to the lab. Had a lot of exciting news to share with you guys. Had a very good conference at Viva last week. We can go over some of the late-breaking clinical trials that came out that showed a lot. We'll discuss that today. But I think more importantly, we have a great case to discuss. Unfortunately, we had a change of case because of insurance issues. As you can imagine, things happen, and therefore we're not presenting the case that we had scheduled for today, but we do have a very interesting case that we're going to show you. So without further ado, I want to introduce the team. To my right is Dr. Vishal Kapoor, who really needs no introduction. He's been with us for almost every single one of these. Dr. Farhan Majid, who's our endovascular fellow this year. Ray Lascano, our interventional nurse practitioner. We've got Marichu Malloy, who's been with us for all these cases, and Damien Cabrera, our tech. We're missing Elizabeth, so if she's watching out there, let's get better soon. And we're going to start with the case presentation. Farhan?
So good morning, everybody. This is a 73-year-old male with a history of peripheral vascular disease. The patient has had PTA of the mid-right SFA and the distal left SFA in the past. The patient also has a history of diabetes, hypertension, hyperlipidemia, and coronary artery disease, status post-CABG. The patient presents with progressive left lower extremity, block lifestyle-limiting claudication, and a left first toe ulcer, Rutherford grade 3, category 5, Fontaine stage 4. The patient's symptoms have been progressive. His claudication has progressed over the last year, and his ulcer has developed over the last couple of weeks. The patient otherwise denies any other lower extremity swelling or pain. His past medical history, as you see, is significant for peripheral vascular disease. He is status post-PTA of the mid-right SFA and distal left SFA in 2013. He has diabetes, hypertension, hyperlipidemia, coronary artery disease. All his bypasses are patent. His ejection fraction is 50%. The patient does have chronic renal insufficiency with a baseline creatinine of 1.8, which it is today. Next slide, please. His medications include aspirin, cilostazol, rosuvastatin, Plavix, labetalol, amlodipine, torsemide, and glimepiride. No allergies, no other social history or family history that is contributory. Next slide, please. As you can see, his examination, his vitals are stable and normal. His cardiovascular exam is normal. He does have diminished pulses bilaterally. He does have a left first toe ulcer. His laboratory data shows a normal hemoglobin and normal platelet count. His creatinine, as noted, is 1.8. Next slide, please. The patient underwent non-invasive imaging. His arterial vascular ultrasound revealed elevated peak systolic velocities in the left mid-SFA, consistent with a 50 to 99% stenosis. He also was noted to have a severe disease in his infra-popliteal vessels. Next slide. So in summary, this is a 73-year-old male with a history of peripheral vascular disease, status post right and left SFA PTA in the past, who presents with progressive severe left lower extremity claudication and a left first toe ulcer. He is found to have abnormal vascular ultrasound with progressive left SFA and infra-popliteal disease, and he was referred for a peripheral angiogram. PK?
Okay, so with that, I'm just going to go ahead and just show the films here. So
So PK, on the right side, the angioplasty was just DCB, atherectomy and DCB? Or?
Yeah, so we did DCB, and it's interesting because one of the things we should talk about in these kind of patients, this is the right leg lower extremity angiogram. He has a tortuous iliac, so you can see he has some mild restenosis in the prox where we did DCB and some moderate with elevated systolic velocities at that distal, say P2 segment of the popliteal.
That's right.
And you can see here that this is a guy who now, is probably going to progress this, and shows the importance of actually watching these kind of cases very carefully and surveying them. So the issue becomes, one issue is, well, you've got elevated velocities on the right, you've got elevated velocities on the left, again with moderate stenosis, but here you have tissue breakdown. Right. So I guess the first question, while we get things ready, is let's just broadly talk about a future problem that's going to occur, is how do you deal with DCB restenosis? Right. Okay, so I'm not saying that this necessarily is a case that's exemplary, but on the opposite leg, you have a patient who's symptomatic now, who has an ulcer on the left side that you're treating, but who has claudication on the right leg, and now you're dealing with DCB restenosis. So I just want to go over some of the algorithms and really throw it out to Vishal first, while I start getting everything ready here, to talk a little bit about DCB restenosis. So Vishal, right, tell me about your algorithm for DCB restenosis.
Well, I mean, that's again a very interesting topic to talk about, especially with DCB coming up recently in the market and use in the last, I guess, a year after this year essentially, early this year when it was approved, and we were the first one to do it. So we've now started to see some patients with DCB restenosis because, the presentation, depending on how aggressive the disease is managed, right, all the cofactors, 6 months, 9 months, so we're almost in the 9-month period. But what my thought process would be to see, first the compliance of the patients, his cofactors, the medical issues. But besides that, from the technical aspect, if you have DCB stenosis, you used an atherectomy and DCB, then my next goal would be probably, even though I'm a believer of nothing left behind, probably put in a metallic, meaning like a stent in this place to give it more patency and more long life to the flow of the blood. So especially with the data with other supera and calcified lesions and silver PTX, with the 3 and 5 year data now coming out, giving us pretty much good primary patency. My next thing would be to evaluate the DCB, whether it's focal stenosis, which most of the times you'll see because of the irregular deposition of the drug. Some places it plays its action very well, some places it's not that good. So most of the time we'll see is, if you do long lesions, you'll probably see focal patchy restenosis rather than diffuse restenosis again. So I'll probably do a focal stenting or at that spot to increase the primary patency and do it.
So Vishal, you would not do a DCB again?
Well, I mean, again, like you've already tried it, it didn't work. It could be again because of multiple, it could be technical reason. It could be that the drug didn't diffuse into the intima as well as you wanted to do. Okay. But going back the same path and trying again, I would be a little skeptical unless there are real contraindication or real technical difficulty of putting a stent in. My second goal, if the patient came back early on, my second goal is to make sure the clinical driven revascularization rate is as less as possible. So I would lean towards putting a stent in if there is DCB-induced restenosis. But again, is there any data to show that? Personally, I don't know unless PK or you know anything about it on the data of DCB restenosis. I think it's an open topic which is all operator dependent and patient driven. So
I think all those points are good, Karthik. I think two things for the audience. So first and foremost, I think we all have to accept that the data with DCBs are really compelling, and DCB should clearly be, or drug-coated therapy, I should say, because I don't want to be remiss about leaving DS behind. It should be one of the primary modes of our therapy in the SFA, FMPOP region for sure, with both the silver PTX data and now the 3-year impact data. So if you look at the 3-year impact data, which I had the privilege of presenting at Viva, you're looking at a primary patency rate in 3 years, duplex ultrasound-derived patency around 65%, 66%. And now the PTA was around 45%, but if you look at the clinical-driven TLR, it was still in the 80s. Therefore, I can tell you the fact that it's clinically effective as well as by hard duplex criteria effective shows that this is a durable therapy. The problem with DCB restenosis, I think you both would agree with me, is that we don't know the mechanism of failure. So like Vishal was so nicely saying, in this vessel, well, we know that DCBs generally, as a rule, and we've learned these from our European colleagues, tend to come back with focal restenosis.
That's
but
right.
the question becomes is, well, what was the cause of the restenosis? And I think that's one of the questions that we're investigating, I know, with some of the companies as well as in our own data. And I think till that's identified, I think what Vishal pointed out was probably my algorithm to treat. You know, I would probably go with a different therapy. I may use a drug-coated stent, giving the patient the benefit of a drug, or I may just use a mechanic scaffolding. So at this stage, I think the jury's out on how to treat DCB. I think everybody has the anecdotal evidence in terms of DCB restenosis. And so therefore, I think with DCB, it likely is going to be you know, either a scaffold or another drug-coated scaffold at this site. I don't know whether you agree or disagree with that.
No, I think I agree, PK. Once you have restenosis, I think there are multiple mechanisms which are explained, right? Initially, when we came in, I know Dr. Broadman explained some mechanisms that, you know, it's lack of expansion. It's always supposed to be 1-to-1 or a little more higher than 1-to-1 for complete apposition and everything, and also diffusement of the drug. As you said, nothing is really explained. I think they can go back on the restenosis patients and see what kind of balloons were used and research, then see if they can find a reason. I think it's absolutely fine. I think it depends on if the patient, for example, like this, comes after 3 years and comes with focal restenosis, you would still go with the mechanical scaffolding, PK?
I would probably. I think like Vishal says, there's got to be a reason for the failure. So I would assume that it's a scaffolding issue and do that. I mean, until further data is available, it's sort of like in the, I mean, I hate to say this because, you know, I don't like to talk like this, but in the coronaries, you tend to just go with another sort of therapy. Right. Whether it's, you know, you're going to balloon expand it further or you're going to do another DES. In the periphery, I think it's pretty similar on what you need to do. Right. So anyway, so let me go over this case for the sake of time. Let's go to the case. So again, let's talk anatomically on what's happening here. So if you see this patient, so we went over the right leg. On the left SFA, you can see here that, Ray, how do I get this?
It's a diffuse disease, huh?
So I got it. So on the left SFA, you can see that the SFA is diffusely diseased. They call the area of high stenosis, but Vishal and I looked at the angiogram carefully. We really don't see an area that we're really concerned with that may be obstructive enough to cause this ulcer. So you can see here at the distal SFA popliteal region, there's just, you know, some mild diffuse disease, occluded anterior tibial. Thank you, Vishal. And then you can see the anterior tibial is diffusely diseased after a short segment occlusion, and then you can see it reconstitutes relatively quickly. But then you can see it's got diffuse disease throughout the course. Next, and then you see here that he's got the anterior tibial runs into the foot. That's obviously the perineal, and there comes the anterior tibial behind, lagging behind. Becomes a little more robust distally. Next, please. And then you can see in the foot, it's robust and actually giving collaterals to the posterior tibial. Although the flow in the AT is less compared to the perineal, and then you can see the posterior tibial coming back at the end. So the question here is, you have a very poor dorsal arch as well. Right. In order, I wouldn't go for it. So what I want to talk a little bit about here is to talk about your strategies. So Vishal, I mean, you have a by angiosome, you have a dorsalis pedis ulcer. Right. You have a poor arch. And the question becomes is, what is your strategy here and what do you want to do?
Well, so like you said, if it's a dorsalis pedis distribution, so our goal is to get direct inline flow. So in this case, especially the AT, you can see there's a short focal lesion with diffuse disease down. I would, if it was me, I would probably go down the AT, improve influence, see how the dorsal arches does. But in order for completion's sake, to make sure the arch gets full blood supply, we don't know if it's a complete arch, an incomplete arch, and how the blood flow is going. We might, as the second step, might get involved into the PT intervention as well. So it's getting the direct inflow as the main goal, and for some reason, if you cannot, then we go for the indirect inflow mechanism. So in this case, if it was me, again, I would probably go after the AT first, and then try the PT for better healing of the ulcer and the tissue. But again, that would be my strategy.
Yeah, I think you're totally right. So what we decided, Karthik, is we talked about it, but I think what I want to do is looking at this, I think, you know, as Clint Eastwood said, right, man's got to know your limitations, right? So for me, you know, I really feel that in our hands, Vishal, me and you can cross the AT, you know, 99.9 out of 100 times.
Right. I know
so I'm not too worried about that. And but I think that being able to establish the PT might help this guy in the longer term because he has diabetic foot disease, he has chronic renal insufficiency, so on and so forth. So therefore, what we decided to do was to go after the PT first, just to show you guys what's happening. So I want to go ahead and show you what we looked at. So first we looked at a nice foot shot. So when you look at the foot shot, again, you need to really analyze the foot. You can see that the perineal comes first, gives rise to the communicating artery, then the dorsalis pedis is robust. But you can see how the dorsalis pedis dies in the mid, and then the posterior tibial takes over. And I'm going to take a better shot of the foot here to show you even a little bit more, to show you what is the blood supply to where we're looking at. The nice thing is Philips is coming out with some nice software, which I heard about in Viva, which is going to look at perfusion. And I know that they're planning on doing some studies, so this is coming. Currently, the only way to assess the adequacy of blood flow at this stage is, in indocyanide green or methylene blue, which we're not using in our lab currently. But with Philips, you can have perfusion software that's actually going to show where the blood is perfusing. So you can see that there. So it's actually dorsalis pedis does supply, but you see that the posterior tibial actually comes up as well. So clearly, we're going to be able. I believe we're going to be able to open the dorsalis pedis. But what we're going to do now is really open the posterior tibial as well. So here, when you're doing these kind of complex interventions, what the key is to remember is to look carefully and look at the ostium of the posterior tibial. So you can see here that in this level, we took a directional catheter down in and we injected, and you can see how you have a little beak. Now you have a large collateral coming off, so you need directionality when you're going to be able to do this wire. So we took a aqua tempo here, but I think you could use a directional quick cross, a directional trailblazer, whatever directional catheter that you want that's small. So then at this stage you don't see the distal reconstitution. So I asked our very own Dr. Ray to give us 2 injections, and you can see here when you inject from above, you can see you have the retrograde filling of the posterior tibial, suggesting that that beak is where you should lead. So now the steps of intervention that all of us profess is you basically want to break the cap, you want to traverse the lesion, and you want to re-enter. Right? So the choices of wire I'm going to leave to you guys, and I'll tell you what I'm doing in a second, but tell me, what are the wire choices that you guys would go with here, Magapri?
But PK, you're going to do the AT today, right?
Posterior tibial and AT today.
Okay. So AT, I know it's pretty straightforward. We should be able to cross AT without any question. So Vishal, what wire would you go to use first?
So in this case, I would probably, because it's like it is a CTO with the beak, I would start with a stiffer wire. I mean, again, you could start with something like a coronary-based wire, which is a Confianza, or you can take even a stiffer wire from Abbott or other like Connect, or any stiff wire which gives you a little bit of. I mean, you already have an angle catheter of a directionality. Anything that gives you that pushability to break the cap would be my thing. So just starting on a conservative basic note, I would probably start with a Confianza and try to poke and see how it goes, and then escalate my stiffness of the wire as and how we see the thing approach. What about you, Karthik?
I agree with you, Vishal. That's what I would start with too. But the question is, I don't see much of calcification here.
Right.
So it's not a bad, and you see that there's a nice reconstitution. So it's probably a atherosclerotic disease.
Triumph.
So it's not a bad idea. You can try an hydrophilic wire first and see. The Confianza might start you off in a dissection plane. So it's not a bad idea to start with any hydrophilic wire, command wire, feel the wire, anything, just to have a feel. If it crosses, it's well and good. If it doesn't, then you can always upgrade to a Confianza. What do you think, PK?
We started. I think my thought process goes like Vishal's does: 018 versus 014, right? And I agree with you. There's not calcium, but as we know, most of these tibials are calcified, right? So when these tibials are calcified, I'm a little worried in terms of how this is going to react as we go forward, and I'm going to need a little bit more of a support catheter for sure. So now I don't know where I am actually, so it's kind of worrisome to me. So I may actually now ask for a little dye, or maybe I need to go with a better support catheter here as well to see what's happening. So let me have a better, let me have an 018 Trailblazer, guys.
Looks like the direction is fine, PK. You can actually see a little bit of calcification right there, right?
But the problem is I'm not getting any support here, Karthik. I'm not able to go through.
So you're going to change, that's different direction looks like. That direction seems to be okay.
Yes, I need to get a support catheter here. So get me a Trailblazer, guys, an 018. So I'm going to go with an 018 Trailblazer.
So PK, what wire is this? It's a Confianza?
This is a Confianza, but I'm going to switch to a hydrophilic wire like a Command or a
fielder wire. Yeah.
A fielder or something like that.
Yeah.
And then have the ability to go to my Connect 018 if I want to and then come back. So I think, as you saw, you have a lot of distal disease.
Right.
So it's worthwhile to try to open this first and then see whether we can get through. If not,
I agree with you, PK.
We just go to the 018.
Yeah, I mean, so, when you have ulcers, the more flow, the better, right?
Well, exactly. I think the angiosome concept is talked a lot about. I think that at the end of the day, we just need to really do as much blood supply down as possible to be able to get this done.
You know, PK, you mentioned that you mentioned about re-entry and everything. So you don't have any problem re-entering in the tibial vessels. You think that false lumen will stay open even though, like you re-enter and.
Well, I don't think necessarily there's a role for a re-entry device, but I think there's got to be the ability to try to push through, and then go ahead and re-enter into the true lumen distally.
Okay.
So now Vishal's going to put the torquer on this, and we're going to try a little bit here. If we're not able to get through with this wire, then we may actually switch over to a Connect and go with an 018 system. I'm just going to pull my catheter slightly back here.
Yeah, it looks like it's right in the calcified area.
See, that's the issue right there.
That's a different direction, looks like. That direction looks pretty good.
Mag up a little, guys. I think this wire is not going to do it. Give me a Connect wire, guys. I'm going to try a 018 now. I'm going to switch out to an 018 wire for a little bit more pushability with the calcium.
Okay.
So this is the Connect 260, right?
Yes.
So this is their stiffer version of the Connect wire. And I think the other one we could try is the Terumo G or the Terumo M. Also we can try as well. I think it's important to have an algorithm of sorts with these wires to decide which one you want to go to. Obviously the V18 is one that we can use. We can also use the Terumo Gold and the Terumo M wires to see how that does, and then keep going. The problem is you have awesome proximal tortuosity. So that's another thing we need to talk about as well in terms of access points. With this amount of proximal tortuosity, would we have done a better job going more, antegrade rather than going retrograde? Because the iliac, we didn't show you because of the creatinine, is incredibly tortuous. So I don't know when you and Vishal go for antegrade versus retrograde.
So I've actually moved to antegrade a lot. So I'm actually for most of the below knees, I'm actually doing antegrades.
Yep, agreed.
I don't know what Vishal is doing now, but I have moved my methods to totally antegrade actually. I'm doing almost 80% antegrade for all the below knees.
Yeah, I think the antegrade is a very good option. It's all dependent on the patient's body habitus. I mean, if it's a big obese patient, it's very hard to get an antegrade straight because if you really see, the entry point is essentially in the belly of the fat and you really have to hit the femoral head. Right. So for me, like you said, if the body habitus is conducive to an antegrade stick, that's the way to go. If not, or other issues such as, like in this case, maybe like severe tortuosity and all that stuff, then I think that's the right, that's a better way to try to get more some maneuverability and torqueability. Yeah. So
I think for us,
this looks like it's going parallel to the vessel, no?
Yeah, I think so.
We can inject and see, but I think it's a little bit parallel to the vessel.
Give me DSA, guys.
1 second.
I think to me, it may be parallel. We may have to pierce back in. I think we're all still in the subintimal plane here.
Yeah.
You can see. I think we got way more to go before we can even talk about whether we're parallel or not, in my opinion. But let's see. Let's keep going a little bit here. It's just the tortuosity and the torqueability is not very good. So it might be worthwhile to do like a dissection re-entry here. So give me a fielder wire here for now. Let me go forward with the fielder. So I think this is the area where you need to start looking at your angiograms carefully and starting to study this. So you've got, here's the one entry right here. You see, so you're not even close to that area where you need to even worry about getting in. So you're still crossing the CTO area first. So I think, we've created a channel. Now let's go with a hydrophilic wire to try to get closer to that by maybe getting through the calcified subintimal space. So let's try here.
PK, did you try DCBs in the tibials when there is long segment disease like this?
Never in this smaller vessel, Karthik. I've never done DCB in anything in less than a 4. So when I feel there's a 4 vessel, then we'll do a DCB. But generally speaking, I don't think Vishal does either.
No.
In these kind of diffuse tibials, we're waiting on obviously the Lutonix trial to give us, BTK trial to give us some more direction regarding this. But right now, I don't think we really have a role for a DCB here, So right now we've got no ability to move forward. Heavily calcified vessel. And I think maybe antegrade might have been the way to go here. Let me try to take this down a little bit more. You can see that it's just not wanting to go.
Because I see some calcification, PK, and it's going a little bit.
I think we're a little bit subintimal, but you're still in the direction of the vessel.
Yeah, vessel.
Yeah, I mean, I think over here, there's clearly no ability here to get this. Give me a Terumo gold tip, please. Let me make this a little bit lower so we can see where we are.
PK, let me ask you this. What's your thought process on like how we're doing the SFAs of, from technical standpoint, a loop versus directional? Do you have any preference for, do you think there's a disadvantage of being a little bit more aggressive in the tibials and going like the loop technique, or do you want to keep it as straight or as streamlined as possible?
Well, I don't know if there's really any issues with keeping it straight or as streamlined as possible in the tibials. I think that for sure you have the ability in the tibials to get back in. At the end of the day, it's still a tube, right?
Right.
So being a tube, I think we should be able to get back into the distal vessel. I mean, knocking off branches in the tibial is not something we all like to do, but I think that if we need to do it to get to where we're getting to get a straight line.
But if you have to, you would take a loop technique?
Yeah, okay. We've done it. It's called like a propeller type technique where you rotate the wire and get in. But I mean, usually that's generally going to occur in larger vessels rather than in these smaller vessels.
Because my understanding was if you make a loop technique and you create a big subintimal space in tibials, does it hurt patient a lot, like after the procedure, because you have created like a hematoma around the artery, or?
I mean, it's not like we've done it often, Karthik. I think that when you need to do it, I don't think it's crazy to do it. It's not like we've done it often. See, this is going somewhere else too. This is way off. Yeah, see? So I don't think that, I personally don't think that that's a right or a wrong thing to do. I just think that in these kind of cases, you just need to do whatever you need to do to get it done. And this is the problem I have with hydrophilic wires sometimes. They tend to go where they want to go. And
that doesn't look like
this wire is just going wherever it wants to go. It's a great wire. Show me a little higher. It's a great wire, but in complex lesions like this, it's going to tend to be very aggressive. See, that's just doing whatever the hell it wants to do.
It's just creating a huge plane there, huh?
Yeah.
Probably, yeah.
Okay, give me back the connect. Go back with the Connect 018 here.
Would you go back to the proximal part of the vessel and try it again and see if you can go in a different direction, PK?
I think we're in the right spot there, Karthik. I just think it's just heavily calcified and not giving us much work here, much help. And I think that's one of the reasons why I wanted to try this. Now, obviously, this is one of those where you can still go subintimal or transcollateral through your pedal loop if you can find it once you cross the other side through the AT. But at this stage right now, I'm just going to give this a few more minutes.
I think that's where the antigrade stick comes into play if you want to do a pedal loop.
No, we've done pedal loops with up and overs. It's not an issue. No muevan, papi. I mean, we've been able to go up and over, snare it, and work. It's not been that difficult. I mean, it depends on the height of the patient, obviously.
But with the tortuosity and everything, you are okay with the pedal loop?
In this, not at this setting, definitely not.
Yeah.
I definitely not at this setting. I agree with you there, for sure.
You just have to keep it medial.
No te mueva, papi.
That looks like a different direction right there.
PP? Okay, no problem. Choose PP. Yep, just doing the same thing.
Yeah.
So you can see it just doesn't want to go there. Nope.
Right there might be a good idea to deflect
I'm trying, yeah.
Same plane looks like. No?
Yep, that's the same plane again.
Do you think that shadow right parallel to it is the vessel, the calcification of the vessel, PK?
In the wall. Or the
I don't know.
Or is it, you think it's a bone shadow? Or
I honestly
right
don't
there,
know.
right there where you're hooking up?
I mean, we're trying to get back in, but it's difficult. Sometimes going an 014 wire with a little torqueability helps as well. I might switch back to the confianza right here to get back in here in this spot. Give me the confianza, guys.
I think we're just running just parallel to the vessel and then it goes out.
You think ballooning the tract proximally with a short balloon might give you more directionality?
It may. It may. I think this is all areas where we do those techniques as needed. But right now, I think that we still got a long way to go to get into that proximal area where we have the lesion. So let me go with an 014 here. It's a little more torqueable.
See, PK, Vishal, I know we talked about this a lot. When PK keeps trying, we'll talk about something, the ulcer management. Like after we do the intervention, let's say we are not able to open the PT, and of course we'll directly go and open the AT, right? We all agree on that. How would you follow up the patient for the ulcer? Like what would you do to see, as PK said, there's not many methods to know the tissue perfusion except TCPO2, right? But how would you normally do it? What is your normal?
I usually mainly follow them mostly on clinical driven and the examination itself. See them in the clinic within a week. If they need concomitant debridement as a part of like healthy granulation tissue to initiate healing, we get the surgeons involved as well. So that way we can at least from the local wound area aspect get the wound care involved and the vascular surgeon involved if needs be. So mainly see how the progression of the disease is, follow up them with close ultrasounds to see how your intervention site is doing, whether there's a recoil or there's significant stenosis or it's a failed intervention. So mainly driven by both clinical and non-invasive imaging as a follow-up.
Do you do TCPO2 as in the outpatient basis?
I do. It depends. Like I go to a few different facilities. Some have, some don't. So it's a little bit technically more. I would love to do it.
Challenging, yeah.
But it's on a clinical aspect. I guess it's more clinical driven in my practice per se. Yes, we might be in the right area.
So it looks like you have some direction there, PK.
Yeah. So it's going in the right direction.
Right there, I think it's getting deflected. So
there is your.
Yeah, give him the PP. Yep. So let's keep working here.
Rather, let me ask you this. A lot of people swear by the V18 wire. What's your experience with the V18?
So I usually don't prefer 018 wires unless like this thing happens, like we are failing confianza and then we can't use anything else stiffer. I usually try to avoid 018s also in tibial vessels, especially when vessels are diffusely diseased and small like this, because I feel like once we use over 18 we create such a big tract, it will be difficult to re-enter back into the main vessel unless you're like really parallel to the vessel. So I use it. If I go from pedal stick, if I take a pedal stick,
Abbott, the other one.
Then I usually try to keep it over 8 because I get more support. Otherwise, I try to avoid it as much as I can.
Oh. Well, I mean, I think that Vishal and I feel that there's a role for all these wires. See, right now, I think the 018 helped me get started. Now the 014 is giving me some fine ability to move this a little bit closer, you know, and then I may need another 018 to pierce this last part here. See, right now it's not going. I know I'm not going to be able to do it with this. So now I'm going to switch back to a different 014 wire called a wind wire, and I'm going to try to take a look. Can you check with my?
So you're just taking a stiffer body wire? It's
just a tip that's a little bit more tapered.
Okay, and heavy
with the wind wire,
okay.
And it's got a little bit, you know, a little bit more.
A gram load?
Yeah, I think slightly, and I may go with the Ashtato 21.
Okay.
And I think this is part of the reason all these kind of crazy cases can't be done as an OBL, because obviously the cost is very prohibitive for all these wires. But this is a difficult patient. Can you get a Ashtato 21, guys, and have it ready for me?
So, Vishal, let me ask you a question. Let's say if we cannot cross this, we do the AT, would you bring back the patient and do a pedal stick from the PT?
Yeah, I mean, I'll probably for complete revascularization bring the patient back up. Of course, see clinically how is he doing, but eventually down the lane, looking at this, I would think he would definitely benefit from a PT intervention as well.
Yeah, I think we should be able to get through this, either if not this time, next time for sure. I mean,
but PK, would you be liberal in taking a PT stick, pedal stick?
No, I think I would do an antigrade here.
Okay.
I think my first algorithm here would be an antigrade.
Because looks like from the pedal stick, you have more, you know exactly where the vessel is, and you'll be able to probably get it better.
It's coming.
I think you're pretty close, no, PK?
A little bit off, I think, but
you see some still staining of the vessel.
Yeah,
so.
I can see it.
There.
It's just behaving like I'm outside the vessel.
Right. Too free, right?
And also the fact that my wire keeps getting stuck. As you can see. All right, give me the Ashtato. Now I'm going to go with a little bit of a piercing wire, Ashtato 21.
Mm-hmm. Vishal, how frequently are you doing pedal sticks? Like
I primarily try to grow antigrade. That's my to-go approach, unless there is like a flush occlusion and you can't even see the stump, and a lot of prohibitive collaterals with just taking off in an acute angle. But if need be, yes, pedal sticks are always there, and we, like you can see, we have our Doppler ultrasound ready and everything. So it's always a quick plan B switch if we need to do it.
Yeah, but I think here,
but in this case, yeah.
Yeah, I think we're not going to. I think what we're going to do is we just wanted to attempt this to see where we're going with this. And then I think I'm out of the vessel here. Give me a little dive, Vishal.
That looks promising, no, PK?
I know, I think I'm top of it.
Oh, you're top of it, okay.
I feel it.
Yeah.
Oh.
I don't know, you're right there.
Yeah, looks like you're on top of it.
There.
No,
yeah.
I'm off.
No, you just feel.
Yeah.
Which is fine, which we'll just get a...
At this point, getting the catheter closer and probably confianza and piercing it, you think?
I'm going to see whether I can get it closer. Doesn't want to go any closer here. Let's go to a different view. It's also important to work on different views, guys.
Yeah, just to see how far you are.
Really, you know, you might be surprised here that you're way off. And if you're way off, you're way off. You abort the procedure and go. Ready? Inject.
I think
So not that off.
still in the right direction.
Yeah. It's just too free. You see that? Give me the confianza here.
Like a big plane?
No, I don't know. Maybe. We'll give it another 5 minutes with this, and if not, we'll switch over to the other one. So now tell me, what is your definitive therapy? Tell me, as far as you guys are concerned, your algorithm to crossing these lesions. Once, obviously, we talked about the different wires, the different access points. We haven't really talked about crossing devices, which I don't think any of us really use. As far as your once you get through either this or the other one, what is your algorithm to treat this in terms of your balloon, stents, whatever, and what is the data you think that supports, and what are your goals of therapy?
So I think, I mean, atherectomy and ballooning, I think, is the best data we have. I think the data-wise, I think Definitive LE has some data, right? And I think eczema trial has some data on critical limb ischemias for below knee, right? So I think the patency rates are still, they say it's like about 72%, right? We don't have any great patency rates with any of the therapies. Standalone PTA, of course, I know there is no major trial which shows standalone PTA. I think a lot of people just do standalone PTA. I prefer to do atherectomy and PTA. I know you do the same. I know Vishal does the same. But I just upgrade my balloons. If I can't get the balloons down, I just go with the coronary balloons and try to expand as much as I can.
What about you, Vishal?
I mean, once crossing, I initially start with, like Karthik said, atherectomy and PTA.
So you both you guys are big proponents saying atherectomy. So why atherectomy? What do you think atherectomy gives you as an advantage to help you with these lesions?
Essentially, atherectomy, the whole idea is plaque modification and vessel priming for, especially in calcified lesions. Now, in this case, it's more of a medial calcification than an intraluminal calcification, but atherectomy still gives me, or I guess from data-wise as well, just gives you a little bit more better patency, especially with the dart therapy. So, I mean, I know the data is not below the knee, it's all in the SFA, but I guess we're just translating our knowledge down to the lower extremity. So I usually go for atherectomy and PTA. I don't know, what about you, Karthik?
I do the same thing, Vishal. I just translate the same thing down there. But I mean, it's been shown, right? Definitive LE has some data. Eczema trial has a data with the laser. It's not like there's no data with atherectomy and PTA. There is.
The problem, Karthik, is that the data is with 7.9 centimeter lesions.
Right. That's
Majority of definitive LE below the knee or claudicants.
Right.
Right. So the you and I really aren't treating claudicants below the knee.
Right.
So the issue just becomes okay, if that's the case, then what do we, is there any advantage to the added cost of atherectomy? That's what I think is the question that a lot of people have with atherectomy. Is there any added incremental benefit without any data, So I think the answer has to go towards wound healing, right?
Right.
So when it comes to your wound healing algorithm, is wound healing enhanced, by leaving the patient on, with more patency with atherectomy? I think that's the question.
Right.
I think the question comes with that.
So, but eczema trial did look at it, right?
Eczema laser did, yes.
Yeah, eczema laser did look at it, and they said that, but they said that it's definitely doing an atherectomy. It looks pretty good, right, PK?
I don't know, man. It's too big a curve because it got all messed up. I think what we'll do is we'll take a look here, and then we decide if this does not in the right plane, we leave it. We'll come back. We'll get it. We'll just got to make sure that we're in the right plane here. We'll come back and get it. But these cases, señor.
No se mueva,
No se mueva.
Okay, one more time.
Okay, inject.
Injecting.
So I think it looks like too big a curve for me. The curve got messed up in the body.
But your tip seems pretty free, so.
I know, but it could be free in the subintimal space or in the area where you don't want to be, which is perforated. But it looks pretty good. You're right.
You're on top of the vessel.
See?
Yeah.
So I'm right on top of the vessel, which the vessel looks even better now. So I'd like to come back here.
And try it there probably?
And try again.
Right
but
there.
Clearly I've got a channel here to do something with. So you can see I'm all over the place now. Show me above.
It's just that the type of disease, like tibial vessels have such diffuse disease, PK. Just by doing, I mean, we know how PTAs do, right? Angioplasties anywhere, in coronaries or in peripherals. The recoil rates for angioplastics have been severely high. That's the reason we are doing all the studies, right? Yeah. Stents, DCBs, DESs. That's what we are trying to do. Unfortunately, we don't have long DESs, so we cannot stent the whole vessel. So I think plaque modification is the only thing left to give a significant, a significant try. I know they tried DCBs in below the knee, and the initial data has not been the greatest.
Show me above. Now give me Señor, no mueva. Inject. That's enough. Not too much.
Yeah.
I like this plane a lot better till I see where it is, and now I don't like it at all.
Yeah, it looks like you're.
Yeah.
I'm just jumping
Keep
on
shifting.
either side of the vessel.
So you would do PTA and not atherectomize PK at any point
No,
of time?
I would definitely do atherectomy. It felt like it broke through there. Let's try here.
Yeah.
Inject.
Hold on. 1 second. Okay. Go.
I see it looks like it just gave up.
Inject.
It just, yeah, that's what happens sometimes with these dissection planes. So you just got to keep at it and then see whether you can get in. Felt kind of good to me, but I'm usually a positive thinker, Karthik, as you know.
Looks. Yep.
Yeah, it looks a lot better here. Yep, it certainly does look a little bit more interesting. Let me.
You
see
can
how
always get the catheter closer, right, PK? and
Yeah,
see?
I'm afraid to push this because it's going to pull the wire back.
But I mean, we
Take the wire
are
down?
planning to give up anyways, right? If this doesn't go into a right plane, so we
Well,
already
let's-
created a plane with an 018 wire, so
See, this is all the catheter goes.
I think the wire was.
So I think I'm going to try to push the wire forward and change out for a little tinier catheter here. Let me just see if the wire can go gently down the stream here. What's that song again? Row, row, what? Row, 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 yeah.
so you're teaching fellows now songs, PK?
What is
trying.
Farhan doing? Yeah,
That doesn't-
row your boat. Row it.
That looks like it's buckling, right?
A
Right
little
there.
bit right there. Let me
Yeah.
see. There's a lot of plaque in this part of the vessel, though. That's the problem. Give me a road map here, Vishal.
Yeah.
Let's do this.
Again, I see some calcified shadow on the back, PK. Is that the vessel or?
That's enough. Might be. We'll find out now.
Just using 5.
No mueva, señor.
I see some calcification right on the back. So
Looks
Yeah.
good. I think we are in trouble now.
I don't know. Looks like we're off to me, but we'll see.
we are off, no, PK?
Looks like it.
Yeah,
Maybe.
because vessel is away from it, right?
It gave in and then it fell out.
It's different direction.
Yeah. I think we're going to go to the AT, guys. We'll come back and get this. Off-road map here.
So PK, you're still refraining from pedal sticks as much as you can.
No, we do pedal sticks when necessary. I think this is just really to attempt to do it, the regular way. But we're going to stop here. We're going to go back to the other one. So let me just make sure that we didn't cause any horrible perforation or anything. And I think this is important for us all to see.
But the PK, the good point was you said is the direction, like change the angulation of the camera.
Yeah, I think those
Let's
are
see.
all good points. Make sure to do a delayed cine here. Make sure nothing bad is happening. So there's our tract.
I don't think we have ever gone out of.
Clearly, I mean, these dissection planes may start to heal, and we'll get something.
Yeah,
So now we're going to the AT here. So I'm going to pull it back up. I'm going to get a
getting into the AT also. AT looks like a very calcified vessel.
Yeah,
PK.
it's going to be calcified.
Yeah.
So what we decided to do here for the AT is, now we talked about different forms of atherectomy.
Right.
So crossing this AT, like I said, we're going to go with the hydrophilic wire first, followed by, if we necessary, to go with stronger wires. There's not the same kind of vessel as the, this wire is gone. Yeah, give me another command.
You have any preference
give me
over the atherectomy you want to choose?
I think we decided to go with the Diamondback on this case. So is that a fielder?
I don't know.
Because we decided to go with the Diamondback, I think we should be okay in terms of doing this. So what we're going to do is we're going to switch over, go to the AT and get the case done in an hour as we promised. So as far as atherectomy below the knee is concerned, I mean, if we look at you have the Lacey registry, which was done a long time ago, which really is not a contemporary sort of registry. I think when you look at other registries, you have the Liberty 360, you have obviously the chocolate bar below the knee, you have a definitive LE. So the most robust out of all of them really is the definitive LE. And definitive LE really looked at lesion lengths of 7.9 centimeters in really a claudican population. So because it was more of a claudican population, it's hard to extrapolate that into what would happen in these kind of patients with CLI. So therefore, at this stage, what we're going to do here is we're just going to go ahead, open this up with some form of atherectomy, right? And with whatever form of atherectomy that we can open this up with, and you can see the hydrophilic wire made its way through, I hope. Yep, it did.
Yeah,
beautiful.
It did.
See? So just take a hydrophilic wire, put it down, right? And then we'll go ahead and do something here with the CSI just to show. So Karthik, I was wondering whether you could talk a little bit about your technique of CSI here. And what are the things that you do, and then I can talk about what are the things me and Vishal like to do, and then we can decide here.
So I mean I don't use CSI. I don't use CSI as much as I use other forms of atherectomy. But definitely, like when I use CSI, clearly it's an orbital atherectomy. It's not a directional atherectomy or anything. So I think the best way to do CSI is a lot of people. There are multiple forms. Some people say you can go fast and make fast, quick runs, but I prefer to make a shorter runs and a slower runs. I think the faster you go, the more amount of embolization you see. I think this is great. It just doesn't form the dorsal arch as you said, right?
Yeah. So you see, there's no arch.
Yeah.
So clearly, you're going to be able to do a CSI here, and you're going to have to really survey this guy closely.
Yeah.
Because the arch really doesn't fill.
Yeah.
So therefore,
anything you embolize is going to go into the interosseous arteries.
And also the important thing here is your posterior tibial. Whether you choose to bring them back and open it or not is different. But clearly, you want to survey these patients very, very carefully. So just backload it now. So what I do with the CSI guys, I want you to look at this. You see the Viper wire.
Can we focus on the PK strands just to see the
curve? So the Viper wire, if you can see it here, right on this wire, please. So you can see we make a real C loop with the Viper wire. Can you zoom in? We can't see it, guys. Right here, my hand. So you can see the Viper wire all the way at the towel. Come on in. There you go.
I see.
You see the C loop on the Viper wire?
Right.
That's what you really want to do, because the key is, I think the three of us have seen, tremendous perforations and stuff going on with this wire.
Right.
Now remember, it's not the wire. The wire is a great wire. It gets the job done. Don't blame the company. Blame yourself. I mean, bottom line is you have to know the limitations of the technology given to you, right?
I agree.
So this is an effective therapy that works in these lesions. But however, you have to respect the fact that the wire is a tough wire. I mean, it's a metallic wire. It's got a very tough tip. It's not very friendly. Likely, we haven't had dissections with it, but we have perforated one case. Again, all fault of mine. It has nothing to do with the wire. So what we do is we try to get a C loop as much as possible. See, now I got a nice C loop.
Nice.
It's a nice C loop distally in a little vessel. I know it's not gonna perforate, but I've got it all the way down there because the wire is protecting me. Now I'm gonna bring back this catheter, and now we're gonna set up the CSI.
PK, you use Viper fluid. You use Viper fluid with the CSI.
Now that's the next thing I'm going to talk about. Vishal has really bought this here. So what we do is we do verapamil with nitroglycerin mixed in to prevent vasospasm. Okay. And I think one of the other things that we do is we do short runs, right? So we do more short runs rather than long runs, similar to you, because I think everybody agrees now. The longer the run with the CSI, the worse the benefit.
I agree.
Of the device. So we're going to do very, very short runs, and we're going to show you what our balloon inflation times are. So I'm going to turn it over to Vishal here. He's going to start the CSI with Ray and Farhan. And I'm just going to step out for a second and come back. I just got to look at another patient. I'll be right back. Go ahead, Ray.
So Vishal, so you run short runs the same way?
Yeah. So CSI usually prefer to run short runs. Usually do 20 to 30 second runs with another 10-15 second delay or rest time, and then restart again. And in between my runs, there's a button will show you it, which is like a flush button. It's on the console as well as on the on the drip IV fluids as well. So we push that just to flush whatever debris you might have or the micro debris you might have, and then restart our runs again. So for below the knee, as you know, it's a smaller burr size. It's a 1.25 burr, which we use for below the knee vessels. So, like PK was talking about, I guess for me the most essential part is how to prep the vessel up. Some people will inject just verapamil and nitro through the sheath or the microcatheter, dilate the vessel and inject it. And I usually like to do is in the fluid itself, you can put in your verapamil and nitro and let it drip with the Viper fluid. So it's like getting a constant flow of verapamil and nitro, thereby decreasing spasms or anything that might come up. So you can see it, there it comes. So that's your burr right there.
So you're going to lock the wire on the back?
So this is the whole console. It's a 1.25 burr, like you say.
So can we focus on, yeah.
Right. So this is your wire lock. It's pretty much like how you use in the coronaries when you have a rotablator, you put a clip on as a lock.
Yeah.
This is the lock. So once you've put it in position, you lock your wire.
Okay.
This is the knob. So this is the knob. If you turn it clockwise or counterclockwise, when it's perpendicular to the long console, it's unlocked. So you can move around. So what we do is once we have in position, we get all the torque and the play in it out of it by just moving it around to make sure it's free.
Okay.
Once we have that, we position it just as like approximately at the almost at the edge, and then we give it a small run to see how it feels. So this is the button which turns off and on. And once you turn it on, we can go do dry runs pretty much like
and there are 3 speeds, right?
3 speeds, right. So you can see the 3 speeds, the lowest speed, the middle, and the high speed.
I know the coronary has 2 speeds, right?
Correct. Right. So in this case, we usually like to start with the low speed and remain at low speed. And after that, we probably do a quick test injection to see if we are happy with the luminal gain. If we are not, then we can go up on the higher speeds. Again, higher speeds means higher runs, more circumferential cutting, more debris. So you have to be cognizant of the fact that you don't, you just give more breaks in between, more flushes and stuff.
What size bar did you use?
This is a 1.25
1.25
That's what we usually use.
You limit yourself to 1.25, you go up on the...
Usually, unless it's a big, huge vessel like in perineal, it's like a 4.0, we probably go up, but usually below the knees, it's 1.25, that's what we start with.
PK, that's how you do it too?
Well, exactly. I look at the size of the vessel the way Vishal does, and generally speaking, if it's a larger vessel, go ahead, you can start. Unless it's a larger vessel, then we're going to go ahead and do it. So right here, so I think like Vishal went over, we're going to let Farhan do it. So everybody hold your breath. So as we go, we're going to go ahead and make a couple of passes. The key is the slow speed is the most important thing. The nice pecking, letting it go forward. Right, you got to go a little bit forward, a little bit fast. Yep, there you go.
That's pretty gentle, Farhan.
Yeah, very gentle, beautiful.
For his height.
See, that's the CTO segment right there. So it wasn't really a true CTO. There you go, beautiful.
So PK, you do how many 15-second bursts?
I mean, we do generally 20 seconds. Is what we do. But this is a long diffuse lesion. Stop there.
Come back.
Yep.
Come back all the way.
Yep.
And stop.
Stop. So now what I'll do is I'll have him advance to 30.
But you flush it before,
so you can see there is a knob right here. You can flush from here or there. Let it flush 10 seconds and you go back.
So Karthik, this is a pretty diffuse AT.
Okay.
It's all the way down. We're going to have to really balloon the entire AT. As you saw, the flow was preferentially faster in the perineal than the AT. So now you can see Vishal, what he's going to do is he's going to advance the bird at 30. And from there, I want to do it all the way up to 5. So right there, that's good. Right there, you can start up to 5. Let Vishal make this pass.
So PK, do you do long inflations of the balloons after this is done?
Yeah, I mean, we will definitely do a prolonged inflation, but nothing changes there for us. So yeah. See, that's the calcium right there. You can see a lot of calcium. So we're going to come all the way back here. Right, we're going to come all the way back and forward, and really try to get this entire area. And I may do another run here at the speed number 2. And do it even a little slower to go ahead and get a bigger, stop right there, good. So go to second speed after flushing a little bit. Yeah. So in between runs, we're going to give nitro and verapamil, we'll flush. Again, it's not recommended by the company. We're going to up the speed to speed 2. And now we're going to go, we rarely go to speed 3, Karthik. I think that it really is not necessary here. I think right here at this stage, this is where you really got to watch your speeds, and really do it nice. And you can see Vishal's doing it perfectly. Taking it all the way down, and you can see this. So give me an 018 long balloon.
So PK, a lot of people do CSI pretty fast. I mean, they believe that the faster you do orbital atherectomy, the better cuts you get. So do you agree with that, or?
Well, see, I think it'd go forward from 5 below, please. I think for me, if you look at the reason for doing CSI, right? So the reason for me doing CSI is not to use CSI as my actual therapy of choice. My actual therapy here is going to be a balloon. Right. What I'm trying to do here is reduce my balloon pressures. So therefore, my balloon pressures should be lower. So what I'm going to try to do is really try to do the CSI like Vishal is doing here, 2 passes at speed 1 and then speed 2, and then go ahead and then do a long balloon, like maybe a 300 balloon or so.
300 balloon, okay.
But, and just leave it up there for a little while.
Okay.
Now, this wire is what, a 01 what?
This-
1.8.
Is it an 014 wire? Then just give me a long 01430 balloon. 30200 014. So over the CSI wire, we're going to balloon. Okay, go now.
Yeah.
And I think we really just need to get to like maybe 15 or so on this AT,
Okay.
and then we'll decide.
All right.
So obviously this is the point. So the point here is, okay, for wound healing, how much time do I need, right, in order to heal the wound?
Right.
And that's why I think I'd like to prevent any dissections if I can help it.
So you would watch for 4 or 5 weeks and then a month or so and then decide if you have to go back to the PT?
Exactly. That's exactly what I will do. Luckily, it's an isolated anterior tibial distribution. I mean, but look at that. I mean, it's pretty poor circulation to the great toe there.
Right.
So it's not, I mean, I would like to get, as you know, the supply of the great toe is dual. So if I could get the PT, I'd be the happiest guy in the world. All the way up to 15, guys. You got to go right there. So that would be the ideal thing for me.
So that spot again looks like it's calcified. And
I think that should be all clean.
That's fine, yeah. Come back now.
probably right at 15 you might want to.
Yeah, that's all I want to do, yeah. Okay, that's fine. So
right,
we're going
let's
to
take
walk it out, and I will take a picture. Now, you know, the dreaded complication is a no reflow, which obviously I hope we don't have, you know, and then we'll just do a prolonged balloon and show you a final result. So, I mean, we discussed a lot of interesting things. You know, it would have been nice to cross that posterior tibial. Obviously, we weren't expecting this patient here today, but the posterior tibial lesion, you know, has its challenges. You could see we didn't cause any harm. We have a robust attempt again, which we will do. You know, the other thing we could do is stick the posterior tibial directly just above the ankle and come from below and meet the wires, which may not be a bad idea, which we would have done if obviously we didn't have the anterior tibial to do for this patient with the ulcer. So right now at this stage, what we'll do right now is take a DSA shot.
It's okay.
So you're saying the transcollateral you would try from the peroneal transcollateral?
I wouldn't do the perineal.
Uh-huh.
I would just do whatever. You bent it? So Varhan bent the wire. So, you know, this is what happens.
Even though with his gentle hands, he's able to bend the wires?
I don't know. Very gentle hands. So, you know, so let's see the flow first in the anterior tibial artery here. Let me go a little bit higher. Isn't it nice to blame a fellow, Karthik?
Absolutely.
It's a privilege.
It's a privilege to blame the fellow.
Very enjoyable.
So you can see there's much better flow now. You see that we did do the right thing up to 15. It seems to be running nicely.
Right.
So go ahead, give me the balloon now, guys,
Yeah.
the 3-0. So we're going to do the 3-0 balloon.
So you do 5-minute inflations, PK?
Probably we'll do 5 here. And there's a 30200 balloon. And like I said, it's a very robust, and we're going to try to go with low pressure. Let's see whether it works. You know, again, everything is relative, right? You know, it may work, it may not work. We'll see. So the 3-0 balloon is going smoothly.
Take it full. Yeah.
So PK, just in case, I mean, we are there. We're doing orbital atherectomy. I know we're ballooning it, and it's calcified vessel. Let's just talk about what worse things can happen. Of course, you said no reflow, right?
Right.
So no reflow, of course. How would you treat your no reflow if you have a no reflow here?
Well, I think no reflow, the most important thing is prevention, right?
Right.
So prevention is exactly what we did here, which is, you know, where's my balloon, guys?
Don't see it yet.
You have to mag up, guys.
Yeah,
PK
I
is.
can't. I'm old.
I didn't say old. But so you would just keep your verapamil and nitro ready all the time?
Yeah, I think prevention is the most important thing. If it truly really is no reflow, then what I would do is then put a transit catheter down and really try to flush out the distal circulation. And once the distal circulation is flushed, I don't think there's any role for thrombolytics. Show me above, because it's all plaque and calcium that's come out. So the dreaded compilation is no reflow, maybe a little bit more, right?
27.
Oh, okay, that's perfect. Let's go up here. We'll pull back.
28. Yeah.
Okay. And
So I think that's the dreaded compilation. So if that happens, that would be my therapy.
okay.
You know.
And perforation, Vishal, what would you do? That's again a possibility, right? Calcified vessel,
Right.
orbital atherectomy, ballooning. So how would you treat?
Well, I guess the primary main two treatment strategy is just balloon tamponade the whole thing. We just go up in the balloon, keep it, stop your anticoagulation, keep the balloon up 10 minutes, maybe longer if needed, or repeat inflations. And most of the times, because it's a small vessel and it usually tamponades off well. Worst case scenario, if it's patient is, of course, if it's a major bleed and you cannot really tamponade it, then you might have to end up using a Jomet stent or any covered stent essentially. But in this case, keeping the anatomical size, probably a coronary Jomet would work. That's our last resort. Of course, we want to make sure there is a watch for the patient's pain, monitor, see if it's getting worse, tenderness, clinical evaluation at the same time while your balloon is up to make sure he's not having any signs and symptoms of possible compartment syndrome. So that's the biggest concern we have. Get a blood pressure cuff, of course. The first thing we do is get a blood pressure cuff around the area of perf and inflated above the systolic, 20 millimeters above systolic, and just keep it up there. So that the external compression also helps a lot in addition to internal balloon tamponade. So
you can see here I'm at 4 atmospheres.
And he's having some pain. He's moving his leg.
No, he's not. He's he's just bored. You know, so he's not having any pain. I think right now it's just the fact that this procedure is taking much longer than it usually does. You know, I just want to make sure that he's not having any pain in the calf where we failed. We didn't, and we're just going to leave it up for a good 5 minutes here.
So PK, if you have large AV fistulas, which is the third problem, right, you can have in these vessels after abortal atherectomy, you have a large AV fistulas, you would do anything for it or just prolonged inflations?
You know, large AV fistulas are, I don't even treat them unless they're stealing the blood from the vessel. I mean, I've done, thousands of interventions now in my career, and I can tell you that I've never had a case with a large AV fistula enough to steal blood from my my major distribution vessel. I mean, we're talking, thousands of cases, probably thousands of tibial clay cases and SFA cases. Right. So I really do not believe that an AV fistula is serious enough to treat. I know there's a current trend of claudication from stealing and things like that I've heard. That's been people coiling off, arteries and AV fistulas. But to me, it's never, ever, ever, ever crossed the problem. Right. I'm not saying that I'm dogmatic about it. I just think that, I can only talk on my experience. If you read the literature, AV fistulas were actually created to increase patency in tibial vessels, and, Jihad and other people are doing covered stents into the veins in the tibials for critical limb ischemia. A technique where they're actually perforating into the vein and perforating back into the vessel and creating like a venous bypass.
That's right.
AV fistula, I forgot what he calls it. So I don't know if all those are going to pan out to be what's necessary, but I do know that AV fistulas are common in terms of what we do, and I don't think that anybody should be treating them in every single patient.
Right. Agreed.
So right now we're at 4, and I'm just going to leave it up for 5 minutes. So as far as follow-up, Vishal, on these patients, I know Karthik talked about that. What is your antiplatelet regimen? What do you do for antiplatelets?
Well, in these patients like this, I would usually put them on dual antiplatelet therapy, aspirin and either Plavix or whatever, any of those analogs for. In this case, probably a month, and then follow them up and see how it is. I mean, is there data on 3 months, 6 months, 1 year? There is no real any literature to support it. So I would probably just put them on a month, see how they respond, get an arterial ultrasound in 1 month and see how our procedure site looks, and then take it from there.
What about you, Karthik?
Same way, PK. I actually do that. I mean, if I have foot ulcers or anything, I do some TBIs or something like that and see. But normally that's what it is. I do exactly what Vishal did. So I don't do TCPO2s that commonly as I'm supposed to do, but.
Well, no, they're pretty tough to do.
They're very cumbersome, especially in a private office. It's very cumbersome to do them.
So I think what we do here is, antiplatelet therapy, we tend to prolong it a little bit more. For an ulcer, we tend to go 6 months with dual antiplatelet therapy. We have no data to support what we're doing. What Vishal said is probably the data, although some could argue that you could extrapolate some data and say that it might be useful. But we do use that a little bit longer. But I think the key is, frequent follow-ups with wound care, weekly follow-ups, see how the wounds are healing, and then decide on reintervention as necessary. We get a baseline duplex at 1 month. So if we have a suboptimal result for a HUN, we'll order it prior to discharge. just so we can get some baseline velocities and we can follow these velocities. Because, you know, if you have a dissection plane that you leave and a month later the velocities come back at 297, you don't know, well, was that the baseline what I left? So then you tend to bring those patients back and intervene. So we have a suboptimal result where we decided to leave it for whatever reason, good flow. Then we'll go ahead and get a baseline ultrasound so we can follow those velocities realistically. But, you know, to me, I think that overall it's just, you know, good surveillance and good follow-up. I think that's the key with these patients.
So, PK, let me ask you an interesting question. I think, Vishal, you have enough experience, and then PK, of course, your long experience. DES in below the knees. How would you guys go about doing it?
So I'm going to let Vishal answer that first. See, it's fully 4 atmospheres right up, so it's beautiful. So I'm going to go a little bit higher here, Karthik, just to get maximal luminal gain.
Just to get the maximum,
So I'm just going to go up to nominal here just to get a little maximal luminal gain. Go ahead, Vishal, go ahead, answer.
So for me, again, stenting below the knee, I really shy away from it unless we have a very suboptimal result after PTA and atherectomy like we did in this case, or you have flow limiting dissection and the patient has ulcer. In those cases, of course, and you want to maintain the patency, I would really go for it, but I'll just go very short focal, but that's not my primary go-to goal of putting a DES to begin with. I think I just put it as my plan B or C in case the results don't satisfy me, and if there's a one vessel runoff, other two are completely occluded. In this case, there's perineal, so it's okay. When other two vessels are completely gone and that's the only vessel supplying, and you want to salvage the limb, yes, I will definitely take a DES. But of course, we have to keep in mind, in case if the patient is a future candidate for bypass, then are we jeopardizing my targets for a bypass? So that you always have to consider in mind before putting in stents, especially below the knee. I don't know what you do, PK, about it.
You know, I do. I think just to talk a little bit about evidence. So the DES with the Yukon, the Destiny, and all the other BTK trials, Sachin presented all these last year in our discussion. Those trials have clearly shown that DES really has the best data in terms of patency below the knee. The unfortunate thing, as Vishal clearly said, is that 1, you could burn a bridge to therapy. 2, you could go ahead and also, obviously, you have minimal reimbursement. And 3, you don't have really an indication below the knee if you want to get down to the nitty-gritty. So therefore, I think the issue here is spot stenting with DES on suboptimal results, like he said. Now, having said that, you know, just recently the BVS data was presented. I forgot the name of the trial in TCT, and the BVS data was presented by Ramon Varco. Very, very exciting results at 1 year. Obviously, he had a special permission from the government of New Zealand to do that. And what we'll do is, in our next live case, I'm going to have Farhan go over the late-breaking clinical trials of Viva. We didn't have enough time because it was just over last week to actually create a slide on each one of the late-breaking critical trials. We can discuss it in our next go-around with this thing. So the BVS study, the BVS may be the future below the knee because it may provide the mechanic scaffold and not burn a bridge to future therapy. So I think right now, Karthik, what we're doing is probably standard. Any sort of atherectomy followed by prolonged balloon, spot stenting, and I think going forward, BVS may be what's going to replace all these things.
All right, good, nice. But you know, in coronaries, PK, I know the data has been okay, but I think the experience for all the interventionalists has been, they've been having some late kind of MIs and everything like that. In that situations, and if it happens in the limbs, it's going to be, I know the long-term data might give us some more information on BBS.
I mean, there's a lot of interesting stuff down the line. I mean, you have obviously the Bard-Lutonix BTK study. I know that Spectranetics is interested in doing a BTK study with the Illuminate data as step 2 of the Illuminate protocol. Then you know that Boston has the Illuvia stent. The Illuvia stent can easily be converted into a below the knee application. There's a lot of exciting stuff coming out below the knee. The only question is, what is the right technology that's going to work at this time? So you know, the important thing to remember is the one thing we didn't talk about, maybe you could talk a little bit about this, is the chocolate balloon below the knee. You know, the chocolate bar registry below the knee was done in Europe, and now they're starting their above knee trial, the chocolate bar DCB study. So what are your thoughts on chocolate or these type of balloons below the knee, Karthik?
As I said, PK, I think chocolate has a significant role. The main advantage of chocolate will be limiting the dissections, right? That's going to be, if it's a balloon with a nitinol gauze around it. So the amount of dissections you create, especially in long segments like this, which you cannot see on regular angiogram, might be limited. So the recoil rates might be significantly less. That might be the reason why it's showing such a high success rate. But again, as you said, below the knee is a totally different animal than above the knee. So none of them have really showed significant results in below the knee.
Yeah, no
I think it's exciting to look for the next era. Next decade is going to be below the knee.
Well, yeah, I mean, but I don't think our above knee problems are solved either. I mean, I think, with 65% is the best we have at 3 years, along with Zilver PTX, which is pretty much on the same same route.
Right.
But I think that we can do a lot better. If you look at the coronary data at 3 years and at 5 years, is certainly a lot better than 65%. Right. So I think we have a long way to go before we declare victory on the SFA flush, please, and saying that we're completely done with that. So I think that everything is going to help. All the data that we have is going to help us. But the only question is, what is going to become that holy grail? A lot of talk about BVS below on the SFA as well, and the question is whether or not that's going to be something that's going to be enough for us to say that whether the BVS scaffold will be fracture resistant or not in the SFA. So inject.
Well, I'm excited about the. I guess we're going to, like you said, Farhan's going to talk probably next time. Is the lithoplasty. It's a very new technology with a totally different concept. And it just got approved by FDA, so that should be one other interesting.
Great, yeah, I just mistimed it. The lithoplasty is very exciting. The data again out of Europe is phenomenal. Now, important to remember, guys. Let's talk about ending of the procedure.
Right.
So you see now, before the perineal was your dominant vessel into the foot, prior to the dorsalis pedis. Now your dorsalis pedis is beating the perineal into the foot. Again, showing good results, right? So the other thing I'm going to do is I'm going to remove my wire, right? So here comes my wire. So again, you want to take your final picture. Ray has taught me this often to take out the wire before doing the final picture. So you could see here as our patient moves, it doesn't really matter. The final picture looks very good all the way down into the foot,
nice
straight
result.
line flow. And then over here, we're going to look at the proximal part, and we're going to be all done here. So you can see, look at that.
Look at this.
See? So beautiful. So, we're done. And I think as far as follow-up is concerned, it's what we discussed. But again, Karthik, thank you very much. I just want to do a little
Thank you, PK. It was a great case.
Thank you. Just a quick wrap-up on behalf of me and Vishal and you. So I think, we presented a case of the non-healing ulcer. So we really talked about the different approaches to this ulcer, angiosome-based and indirect and direct angiosome. So we looked at the angiogram. We realized there was very poor formation of the pedal arch. So therefore, we decided to give an attempt to the posterior tibial first, knowing that in our hands the anterior tibial is something that we would cross without a problem, even though it was a short segment occlusion. So we went ahead. We demonstrated the wire escalation technique for the posterior tibial with catheter support. We used a angled catheter to engage into the ostium of the posterior tibial artery, after which we escalated from 0.14 to 0.18 wires, and again, trying to get as close to the ostium, to the distal reconstitution zone as possible. We were successfully able to pierce the tract, but we became subintimal, and we were unable to re-enter the posterior tibial at the distal reconstitution. However, again, the goal of our therapy is to have straight line flow into this ulcer. So at that time, we decided to abort that procedure and bring the patient back for an antegrade approach with possible posterior tibial stick, though not pedal stick, maybe distal posterior tibial stick, and we'll do this at a later time. At this stage, we wanted to go ahead and revascularize the anterior tibial. We knew that the CTO was a very, in our opinion, easier CTO, so we crossed with a hydrophilic wire without a problem. Well, with a little bit of problem, but we were able to get right through. And then we went ahead and demonstrated the different types of atherectomy and discussed the different types of atherectomy. Dr. Kapoor talked about the importance of adding vasodilatation to the actual flush, which we did by adding nipride as well as verapamil into it. And then he demonstrated the technique of atherectomy. Slow, long passes, slow, short passes in 2 different speeds, exhibiting great patience. Important to remember is that you need to really make the wire, which is a great wire for the purpose of the atherectomy, but could cause complications distally, to make a C-loop and place it safely in a distal vessel. After the atherectomy was performed, we decided to do prolonged balloon angioplasty with long segment balloons, and we were able to do that for 5 minutes times 2. The distal runoff is phenomenal. The distal vessel is phenomenal. I think this patient will do really well. We talked about follow-up and antiplatelet therapy. So again, I thank all of you, and I thank Dr. Guja and Dr. Kapoor, especially Dr. Guja, for taking time out of his busy schedule. He's aiding Trump and Clinton with their policies, but I appreciate you, Dr. Guja.
I don't know about that, but
thank
sure.
you very much.
Thank you, team.
See you next
Great
week.
job,
Thanks,
PK.
man. Good job, man.
Vishal, good job. So thank you guys for watching the live case. We would love to hear questions from you at info@peripheраlinterventions.org. The previous live broadcast is already in the archives. You guys can go and watch it. If you have any questions, please do email us. This broadcast will be later on this week, will be in the archive. And please join us for the next live case, which is on October 26th on a Wednesday at 8 a.m. in the morning. So thank you so much for coming in. Have a good day.